Dr. Charu Bamba. She is a professor and consultant, Safdarjung Hospital, and her area of interest is emergency and pediatric anesthesia. Welcome, ma'am.
I am Dr. Charu Bamba. I am going to talk about newer airway devices. So I've taken the liberty of defining newer as those devices that we have got in the last 5 years, and also hopefully some that we'll get soon in the future. So the ABCs of anesthesia, or should I say anesthesiologists, airway remains our priority. So we cannot even enjoy a good cup of coffee till we have controlled the airway. So it remains the most important thing for us. The first clear reference to orotracheal intubation was in 1788. And these are some of the pictures that I could get of old airway devices. They look rather frightening, rather cumbersome, and difficult to manage. So obviously there has been a lot of progress since then. And any development of a new product requires a lot of R&D, a lot of research, a lot of ideas and implementation. And that is when we get the new and improved products that we are going to talk about now. So let us begin with the humble oral airway. Our conventional airways, oral airways like the Gittels airway, they stimulate the gag reflex by touching the posterior pharyngeal wall and thereby induce vomiting in some cases. So we are not able to insert them in conscious patients, difficult in semi-conscious patients, sometimes difficult to hold them securely in place. With the Mann-Max airway, these problems have been overcome. This airway is better tolerated since it doesn't stimulate the posterior pharyngeal wall. There is hardly any gag reflex. It's very easy to insert. There is no need to measure the size of the airway, and it acts more or less like a bite block along with the airway. So this is the picture of the Mann-Max airway. It is a Y-shaped, made of safe plastic. As you can see, it is not stimulating the posterior pharyngeal wall and thereby doesn't lead to too much vomiting. A study published in the Journal of American College of Emergency Physicians 2021 proved this product to be very useful, particularly in conscious and semi-conscious patients. Supraglottic airway devices. We have a plethora of them. We have a plethora of supraglottic airway devices, but we are still in the search for that one perfect one. So the limitations that our current devices have are that due to the curve or the lack of curve, it is difficult to negotiate the oropharynx, particularly for beginners. The suction opening is sometimes small and it's not very efficient to suck out gastric secretions. The laryngeal opening of the cuff is sometimes so big that the esophageal opening comes within that and increases chances of regurgitation. We need to measure the cuff pressures and seal pressures to keep it safe and prevent complications. There are no bite blocks in these devices. So the newer generation or third generation, as we may call them, they have tried to overcome these problems by developing a self-sealing cuff whose pressures doesn't have to be checked constantly. They have changed the curve of the devices, which also enables direct intubation. They are mostly provided with bite blocks. Now, all devices don't have all these developments. We'll discuss a few devices. The first one we discuss is the Buska mask. It is made of biosafe grade silicone. It has a self-sealing, membranous, variable pressure, non-inflatable cuff. It means during inspiration, the cuff inflates and seals the airway. During expiration, it equates with atmospheric pressure. There is a high flow gastric reflux suction clearance system in the sense that the distal aperture is very large comparatively. It has two cylindrical tubes that lead from that sump cavity on each side of the tube. One can be left open to equate the pressures with the atmosphere. The other has a 90-degree elbow, which can be intermittently connected with a suction. There is a tab on the mask to change the curve of the airway to make the insertion easier. It has an integrated bite block. I'll show you the picture of the airway device. Here it is. This is the ventilation tube, the two gastric suction tubes. This is the 90 degrees suction angle piece. This is the bite blocks. This is the tab, which will be better understood on the video. This is the self-sealing membrane. This is the cuff, small-sized orifice, and this is the large gastric reflux drainage system. So this is the tab which you can pull. As you can see, I pulled it to change the curve of the device to make it easier to insert. We found it easy to use the device, and the learning curve is not too steep. The blockbuster LMA. This is another development. The airway tube curvature has been changed to more than 95 degrees, which matches the oropharyngeal curve, makes it easier to insert. It has integrated wide block. A guidance device in the cuff area allows the endotracheal tube to be directed towards the laryngeal opening directly at 30 degrees. The gastric tube insertion is easy. It has a small sputum collection device, which might be useful in a certain situation. It has a 4-way connector for better fixing of the device. So this is the 4-way connector. And this is the drainage system. There is a flap behind it which guides the tube towards the larynx. There's another device called the LMA protector. This too is made of biosafe silicone. It has a dynamic curve. This too has a dual gastric drainage channel. It has 2 seals, one for the oropharynx and the esophagus. It too allows for direct intubation, and it has an integrated cuff pressure monitoring system. This is the integrated cuff pressure monitoring. So this is the ventilation tube. This is the dual gastric chambers. This is the first seal, oropharyngeal, and this is the second esophageal seal. So T-Rex, they said, we hated repeated attempts at endotracheal intubation. So one of the reasons for dinosaurs getting extinct, we couldn't take that chance. So here is another device to make our intubation easy. It's a video-assisted intubating LMA, or the Total Track. This combines a 2nd generation supraglottic airway device with a video laryngoscope. This is the picture of the device. Studies are showing its efficacy to be equivocal. Now we come to bronchoscopes. There is a newer bronchoscope called the flexible intubating scope, which is no longer uses the technology of a fiber optic bronchoscope. A fiber optic bronchoscope, in that the image used to be conducted via bundles of optical glass fibers. In this, there are no optical glass fibers. The image is carried electronically from the tip, where it is sensed by a chip, which has a light source as well as a small camera, and the image is transmitted to a proximal camera. They come in various sizes for children, adults. Same uses, so same use profile, same indications, contraindications as a fiber optic bronchoscope. However, it is far less expensive, and the image quality is superior because you don't see broken fibers, those black spots on the meshes like you see in this image of a fiber optic bronchoscope. So this is a fiber optic bronchoscope, and this is a video and endoscope. So it's also called a flexible intubating bronchoscope. So they look the same, their profile is the same, the only thing different is the technology. Now, this is a useful new development, the new flexible tip bougie catheter. As the name signifies, it's a bougie with a flexible tip. The flexible tip makes it easier to navigate the larynx. There are sliders on the bougie which you can manipulate, and they change the curve of the tip. You will understand this better on the video. These sliders don't pass through the glottis, so there is no trauma. The silicone tip is blunt, so there is no trauma. It is also brightly colored and latex-free, making it safe. This is the video of the flexible tip bougie. These are the sliders which he is moving with his fingers and thumb and changing the direction of the tip. This is the tip of the bougie, and these are the sliders. The picture I've enlarged for you to see. The new development, or newer, should I say, development in endotracheal tubes is the microcuff endotracheal tube. Now, this is significant for adults as well as for in pediatric age group. However, it's revolutionized the use of cuffed endotracheal tubes in the pediatric age group. Now, we all know that it is safe to use, it has been shown to be safe to use cuffed endotracheal tube even in very small children. However, in these microcuff endotracheal tubes, the cuffs of high volume, low pressure, causing less trauma. The cuffs are made of ultra-thin polyurethane foil, unlike the old PVC cuffs. The Murphy's eye has been eliminated to enable the cuff to be more distally placed, and the seal occurs when cuff pressures are less than 15 centimeters of water. The use of this material also eliminates the channels that are found while using PVC cuffs. In these channels, the secretions cross and can lead to aspiration. All these factors combined make it very safe and cause less trauma to fragile airway structures. The airway is completely sealed, which allows for low flow anesthesia, as well as it is safe to use in laparoscopic surgeries. This is the image of the microcuff tube and the microcuff and the PVC. As you can see, it's thin material compared to that. There's a Murphy's eye. The image may not reflect, but this cuff is far more distally placed than that in the conventional tube. A very interesting development is the AG Cuffil. This is like a 10 cc syringe, which you may carry around anywhere in your pocket. Very simple, very easy to use. It is a device which accurately measures both the pressure and the volume of the tracheal cuff. It's a very objective measurement, therefore it minimizes human error. This is the device. It can be used multiple times, but they recommend one device for one patient, one cuff, one patient, to minimize cross-infections. I think it has come, advertisements are beginning to come, but our institute has yet not received this device. In a video endoscope, I'd like to discuss the TAR scope, or the Anesthesia Society scope. This is a video endoscope or video laryngoscope which has been indigenously designed by a member of our own fraternity, anesthesiologist by the name Dr. Mangal Dave. He designed a channeled, anatomically angulated video intubation aid. Its USP is that its endoscopic camera can be connected directly to the mobile phones and tablets, thereby making it far more reasonable and cost-effective than the conventional video endoscopes. A study conducted by Ramani Kaur et al., published in IJA in 2019, she assessed the efficacy of this device and found it to be useful in all circumstances. Yes, the time taken to intubate with the TAR scope was more than that to intubate with a direct laryngoscope, but that is usually the case in comparison with most video laryngoscopes and direct laryngoscopes. This is the TAR scope. This is the channeled blade through which the tube is passed, and as you can see, that this is connected with a mobile phone. A newer ever technique that has developed, again to increase the safety of our airway, is called the SALAD. It is suction-assisted laryngoscopic airway decontamination. As the name suggests, it's a suction technique which decontaminates the airway as well as assists in the laryngoscopic intubation of the airway. It prevents airway soiling when it's particularly used when there is copious regurgitation. It's the best to explain the technique with a video, which I'll proceed to do. Kindly excuse the slightly poor quality of video. I'll talk you through the video. She is doing the suction of the oral cavity with a rigid suction catheter, continuously doing suction, and now she's using it as an aid to lift the tongue and helps in insertion of the blade of the laryngoscope, continuously performing suction, because this is supposed to be a situation of copious regurgitation. Now she removes the suction catheter and puts it in the left side so that the glottis, while continuing to do suction, so that the glottis is visible. This is the laryngoscopic view. Suction process is continuous. She's continuously doing suction of now the airway is controlled with the endotracheal tube. The cuff is inflated and the suction catheter is passed into the opening of the esophagus. In my anesthetic career, from when I was a postgraduate to now, I've seen that the fear of managing a difficult airway has really, really come down. And it's mainly because of all these airway devices, endotracheal newer tubes, newer video supraglottic devices, and video endoscopes. I hope in the next 5 to 10 years, with better gadgets and even more better devices, this phrase will be removed from our vocabulary. Thank you.
Thank you, ma'am, for such informative presentation. We have a few questions. So one resident is asking, can we use LMA for a long duration surgery with Educate, NPO and glycopyrrolate cover? Yes, ma'am.
With the newer airway devices, they have definitely become safer. Gastric tube was in second generation, and now we have double gastric tubes, wider gastric openings, and so it is becoming safer. I don't think there is any literature says that these many finite hours can be done on the supraglottic device. So you have to take your call, and also depends on the monitoring and your infrastructure.
One more question is there, ma'am. What is need of 2 gastric ports present in Blockbuster SGA?
I think it was in the talk, the first port, there are 2 ports. The first one is to equate, like what is the problem with the current generation supraglottic devices? When you suck, when the pressure is so high that the mucosa comes into that gastric outlet. So now you have gastric port. So now you have 2 suction ports. So one will equate the pressure and the second you can do the suction. That is the purpose. Also, that it can be used as a ventilation channel when the ventilating channel is blocked for whatever reason.
Thank you so much, ma'am. I think.
Can I ask one question?
Yes, sir.
Yeah, Dr. Charu, madam.
Sir, good morning, sir.
Very good morning. It was a good presentation, but I think there are a couple of things which are being missed in your lecture, though you covered pretty lot. But I think there is something like newer airways, that is Elisha airway, Elisha LMA, then there is Orogain and AirQ.
Sir, these are there. If I may just, I have tried to stick to the last 3, 4 years, 5 years. These are there, sir. They have come before 5 years. Actually, even Buska and Blockbuster have come earlier, but we have got these very recently.
Even Buska has come much more earlier.
Okay, sir, maybe, but we got it about 4 years ago.
Well, I know I have met Buska. He was invited in our hospital as one of the guests. But I think Elisha, AirQ and Orogain are the ones which are being asked in the recent advances chapter.
Okay.
Want any detail? I can send you later.
No,
you can give me your.
Thank you, sir.
Thank you so much.
Thank you.
Thank you so much. But it was a wonderful presentation.
Thank you, sir.
Yeah.
Thank you so much, Charu ma'am. Thank you, Ketu sir. Thank you, Amita Sani ma'am. That was wonderful.
Thank you. Actually, I just want to say that, can I say something?
Yes, ma'am. Sure, ma'am.
I just wanted to say that, yeah, we've started using line of sight, but because it's actually easier to remember. You don't have to mug up anything. So we've started using that. And thank you, Charu. I think some of the devices we also didn't know about. So thank you.
But I think I tell you one thing, even that Charu madam, what you describe about the Stilet, I must tell you, in the good old days, maybe about 20 plus year back, I have used a Stilet like that thing, what was a sort of a light band, which was more or less same. I think we didn't put it with laryngoscopy. In fact, we used to just put it in through the nose and just observe your front of the neck, so that are you entering into the trachea or not. So we have used, and that was also flexible, also was available in those days. I think you are muted, madam.
You're muted.
Okay, that didn't have that had a light source. So this one doesn't have a light source. This is a conventional Stilet.
Yeah. These had the light source. These were the light source. Yes.
Yes, sir. I remember seeing it in my residency days. Sir. Yes.
And thank you, Dr. Mohandeep Kaur Madam Ji, for inviting me also to be a part of this prestigious institute. Thank you so much. Thank you, Shripriya.
Thank you so much, sir.
Okay. Thank you, Team RA.
I thank everybody for being there and all the faculties
you,
as well
ma'am.
as the chairpersons. Thank you so much. The first session being held in time. Thank you so much.